Okay, ladies and gentlemen, I'd like to welcome you to this workshop on the underactive bladder and voiding dysfunction, and we'd like to give you new insights in especially underactive bladder and when to think about this condition when you have patients with voiding dysfunction. We're going to look at a general overview which will be given by Professor Chapple, who doesn't need introduction, I presume, and who is author of already many articles on underactive bladder as well. And after that we go to the male patients, and Matthias Elke will tell you about that. First, Kevin Rademakers would also tell part of this, but he was not able to come. So Matthias Elke will give a talk of half an hour in total, and he will cover both items which are listed here on the schedule. And then after that I will talk about when to think about underactive bladder in the female with voiding dysfunction. I would like to give the floor to Professor Chris Chapple.
Thanks very much. Thanks, Homer. And I just wondered, can we have the lights down the front? Is that possible? Thank you very much. Perfect. Okay, well, thank you very much for giving me the opportunity. And certainly, underactive bladder is one of the areas of functional urology which has come to the fore in recent years. Disclosures. And certainly what I'm going to try and do in the time allotted to me is to cover the existing knowledge base before getting on to the new aspects. So the first thing always, we have to start with terminology, definitions and symptoms. And of course, following the format of the ICS, it's very important, of course, to always think of symptom signs, the urodynamic and functional basis, the condition, and then, of course, what treatment we're dealing with. Now, we're all familiar with the genesis of lower tract symptoms as a concept and how this has developed in recent years from just being applied to the male with lower tract symptoms to being a generic term which includes storage voiding and post-micturition symptoms. And of course, there's nothing new under the sun. Going back to the genesis of urodynamics from the group that described video urodynamics, one's always got to realize that the bladder is not a reliable witness because symptoms aren't disease specific. Patients actually describe them in different ways, and of course at the end of the day we all interpret things in different ways. So there's nothing new under the sun, although things keep getting reinvented, don't they? Now, of course, it's very important to realize when you're using words in whatever language that the words mean what you mean them to mean, not what you would like to interpret them to mean. And with this in mind, of course, there are a number of terms that have been implied in this area. And of course, we've got areflexia, atony, decompensation of the bladder, underactivity, chronic retention, and of course the only accepted term until recently, of course, was Detrusor Underactivity, which is a urodynamic diagnosis described in the ICS Standardization 2002. And this is a urodynamic diagnosis where the bladder fails to contract adequately. The term underactive bladder has been applied in recent years, but until just recently, in fact today where it was discussed at the Standardization Committee, there wasn't a draft working definition, which now has been accepted by the ICS. Because at the end of the day, could you consider a concept where underactive bladder relates to Detrusor underactivity rather as overactive bladder relates to Detrusor overactivity? And as you all appreciate, although people misuse the term overactive bladder, only 40 to 60% of women have Detrusor overactivity with overactive bladder, and between 60 and 90% of men. So there is there's a mapping, but it's not absolutely the same, and the same would apply with underactive bladder and Detrusor underactivity. But it's a more complex situation, as I hope I'll convince you by the end of my talk. Because although underactive bladder is avoiding dysfunction, it incorporates all the symptoms that you might imagine. And here's an early publication which was put forward, as you can see here, from Korea, where they looked at the symptoms associated with urodynamically proven Detrusor underactivity. And you can see in men and women, men on the left, women on the right, and you can see that whilst it might be avoiding dysfunction, storage symptoms, particularly in men and women, feature quite significantly. Because at the end of the day, if you're not emptying the bladder, then you've got the principle of voiding efficiency, where you have to relate a residual to the functional capacity. So as a consequence of not emptying your bladder, you end up with voiding symptoms. And of course, as you all know, within the concept of lower tract symptoms, which applies to both sexes, you've got voiding, storage and post-micturition symptoms. And of course, there is this overlap, and that is where the problem lies, and particularly an overlap with bladder outlet obstruction, of course, and that is a factor which is going to be discussed in more detail by Matthias and Clement. Now, if you look at some recent publications, this is a publication from Bristol, looking at a retrospective series of nearly 1,800 patients who'd undergone urodynamics, and no surprise, a high correlation was with Detrusor underactivity, with voiding symptoms and so on, but there were other symptoms that came into play. And I would encourage you to read this publication in European Urology, because I think it gives you a good insight. In the time available to me, there's no way I can go into great detail. A definition was put forward by a working party within the ICS, and I believe today it was accepted following consultation without any revision. Then certainly the concept has been applied, and this was applied again to a prospective study carried out by groups in the UK, looking at 47 patients. You can see here consecutive patients, 15 were female, and you can see that, just to summarize it, a number of symptoms were evaluated, and the principle of this is to try and provide a test bed so you can actually look at a potential symptom assessment tool which will be based on what patients think is important. And you can see this was also presented, I think, at the meeting yesterday, this meeting. So I encourage you to look at that. But of course, within this, you've got to realize that the conclusions are that the interviews have increased our understanding of patient-reported outcomes, but there's a range of storage and voiding symptoms I've mentioned, and the patient-reported outcome measure needs now to be psychometrically tested and go through the formal process. So that definition, which was being put forward, of course, within this, although underactive bladder is a storage dysfunction, they're both voiding and storage symptoms. And one's got to bear in mind gender, because of course that has an important part to play in voiding function. The age of patients, as I'll show you epidemiologically, there's a clear association between underactivity and age, and of course neurological status, because without doubt the bladder's function, both voiding and storage, is integrally involved with neurological function and an intact neural axis, and I don't think anybody would dispute that. And of course there are other particular groups that one has to consider, and of course the bladder diary is important, the flow rate and the pressure flow assessment. So really you need to have both a qualitative and a quantitative approach to things. Remember that symptom assessment is the objective assessment of subjective parameters, and urodynamics is the subjective interpretation of objective parameters. And people often forget this. Urodynamics is only as good as the person carrying out the urodynamics and the accuracy of the machine being used. So the problem with anything that's integrated from that will depend on how well it's carried out. And as you all know, as confirmed urodynamicists, if you do large studies, up to 30% of the studies have to be thrown out because of poor methodology in the centres, and that's a problem with urodynamics, if you like. The ICS has addressed that with the standardization report, but all too few people actually interpret it properly. In terms of diagnostic tests, of course, we have the ICS definition of normality, and then we know that for a given detrusor contraction, the magnitude of the recorded pressure will depend on the degree of outlet resistance, and of course you can see a patient here where you'd all recognize that there's a relatively poor contraction of the bladder. But the problem, of course, with this, it depends not only on the contractile strength, which it's difficult to define, and nobody's been accurately until recently been able to investigate that. We'll hear more about that in a minute. But also the duration of contraction and the bladder emptying time are important. Of course, you may have no contraction at all, but the problem there is it could be the so-called bashful bladder because of the embarrassment to the patient that they're not actually able to contract the bladder. And of course you need to therefore consider the relevance to differentiate between whether it's important to think of underactivity and acontractility in the continuum and how you can define that continuum. Of course, everything goes back to the work of Griffiths, and I encourage all of you, as you know, I think it was last year, from the journal we encouraged the ICS, and they actually republished the book from Derek Griffiths, and it's a fantastic little book. When you've read that, certainly in my case for a day or two, I understand what urodynamics is all about, and certainly this is the basis for all of our understanding, the hysteresis pressure flow relationship that Derek Griffiths first defined. And you're all familiar with the standard ICS normogram, and the principle of that, of course, which is based on the Detrusor pressure at maximum flow and the maximum flow, and the way in which you can integrate information out of that. The limitations, of course, is it underestimates the contraction strength, because, of course, there's a variable blood outlet resistance, and, of course, there's variability in blood outlet resistance, which is important to bear in mind. And the normal ranges are less well characterized, because again it depends on the publications that are out there from the centers that have looked at this. You're all familiar with the Abrams-Griffiths number, which is based on this calculation, the Detrusor pressure at maximum flow minus twice the maximum flow rate, and if you're talking about the equivocal group, 20 to 40, unobstructed less than or equal to 20, and above 40 the obstructed group. Then, of course, you want to try and get on to the power of the bladder, the Watts factor, and again here you've got the other extreme with a equation which you can see there is really quite complicated, and for a urologist like me difficult to understand the basis for this, but this has been well defined. The advantage is it's not dependent to a great extent on volume, but the limitations, it's complex, the calculation, and there's no variability cutoffs. This is just looking at the way in which this can be plotted out, where you're looking at the Watts factor. And of course this all goes back to being projected from an isovolumetric pressure, the PIP, and its derivation based on that, where you're going back with a closed outlet, a sudden closed outlet, to look at the isometric pressure. But the problem is that there is still uncertainty about what the normal parameter that you should use, the normal constant that you should use, and it may also vary with age, and this yet has to be defined. So it's not, I would suggest to you, set in stone at this time. But suffice it to say that a weak contraction is around 50 to 100, and a very weak contraction is less than 50 if you use that equation. And this just shows the advantage, simple to use, easy to obtain, as long as you've got accurate urodynamics, and it's an estimation based on the isovolumetric contraction. The limitations, it may not be applicable to other groups, and that's what I've already mentioned, and it's also a poorer retest reliability than just a stop test, because again that's not an absolute, doing a stop test. It depends on the circumstances, and it's very difficult to do in women. Of course, people have looked at other types of approach, and you can see here looking at strength, occlusion tests, but again they're not very physiological. The advantage is they may be easy to use, and some good retest reliability in the male population, and with no calculation, but of course it's impractical and painful in some patients. You can't do it easily in women, and you can underestimate the contraction strength, and you need to repeat the voiding phase on more than one occasion. Okay, so we have urodynamics, we have definitions, we've got a scientific basis for doing this, but it's not without its limitations. I hope I've shown you in this brief overview. So what about epidemiology? Ideally, you'd want to go out in the population and look at surveys and look at existing databases. But the problem is, of course, you can't have urodynamics at a community level. So you have to rely upon data which is based on symptoms, with the limitations I've mentioned, free flow rates, which also have their gross limitations based on volumes voided and the way in which there's a learning curve with that, the post-voiding residual, which people don't usually relate to the functional capacity, which is the volume voided plus the residual, and of course the concept of urinary retention and how you define that. So if you look at the world literature, just to summarize it, Detrusor underactivity, based on these limitations, seems to affect between 9 and 28% of men under the age of 50, and 48% of those over the age of 70 undergoing urodynamics. So it is not an uncommon problem. So this underlies the discussion about the use of urodynamics prior to doing prostatic surgery in men of this age group, where there may be underactivity, which you can't differentiate based on the simple non-pressure related urodynamic tests. And of course, if you look in women, it's also found in up to 45% of women undergoing urodynamic studies in the older age groups, and particularly if you look at the institutionalized elderly, it's very common. So let's look at some of the literature. This is a recent study on a website, and you can see here this is from Chancellor, where they took a non-validated questionnaire which was put on a website, and patients then, if they logged onto the website, could then diagnose themselves. This has got no scientific fact to it, and it is completely unreliable. So this is what we're trying to get round, to be honest, because this means nothing. Because you can just take any number of symptoms you want without any thought and then diagnose a problem. This is a more valid approach. This is an Australian study which used urodynamics and came up with a similar conclusion to the summary that I gave you earlier from the world literature. Around a quarter of patients, you can see there, particularly at around the age of 60, had Detrusor Underactivity on urodynamics. So you can see the problem. We have a very weak epidemiological base, but the evidence from patients coming forward for urodynamics would suggest it's not uncommon as a problem. So of course, what about the etiopathogenesis of this? Well, of course, you've always got to start peripherally, and we know from this society the importance, as Karl-Erik Andersen and others have shown, of thinking about the fact that it's not just the detrusor muscle. The detrusor muscle is the workhorse, but at the end of the day, the functional bit is the epithelium in the suburothelial space. Because we all recognize that the emphasis of treatment nowadays is the afferent system. And in fact, with few exceptions, most of the drug therapy we use gives a positive effect based on afferent mechanisms. The detrusor effect can sometimes produce unwanted side effects. So if you go from the afferent system up through the periaqueductal grey matter, and work, of course, from Claire Fowler and Chet de Groot and others, where we recognize, although we don't really understand it, but as far as our level of knowledge goes, and of course Derek Griff is also involved in this, using imaging studies which have their limitations, because using functional MR studies with a patient lying flat in a machine and trying to void there is hardly physiological. Having said that, we recognize, all of us, that the emotional centers, the limbic system, is the controlling area. And this slide from Claire Fowler, where she gave this lecture many years ago at this meeting, shows that all the time you're sitting there, you've got afferent impulses going up to your brain, which are feeding through to the limbic system, the emotional centers, and there is a continuous inhibition of the pontine micturition center until volitionally, at a convenient time, and you're in trouble if you don't have that control, of course, as we all know, if there's neurological disease or cerebral problems, then of course permission to void and you empty the bladder. So not surprisingly, there's a whole legion of different conditions which can affect this neural axis. There's of course neurogenic problems, and you can list all of them. There's of course the majority where we don't have a cause, just like for overactive bladder, where without doubt there's a neurological problem underlying the symptom complex in the majority of cases, but we haven't been able to define it. There's the functional problems, the Fowler syndrome, and this is a syndrome I defined with Claire Fowler and Tim Christmas when we were residents of the Middlesex Hospital and published in the BMJ. And of course myogenic pathologies, the use of drug therapy, and iatrogenic problems. At the end of the day, we recognize it's a complex area, and the trouble is when you can draw nice diagrams like this from the chapter we did in Campbell's, whilst it's very nice to actually do this, at the end of the day, you can't separate out these different aspects, because any of the conditions that you see in clinical practice overlap across the board, involving many of these different sectors. And so any attempt to try and simplify it usually leads in clinical studies with a limitation. At the end of the day, we realize that it's incomplete bladder emptying, avoiding dysfunction. We recognize, as recent other work has shown, published in Urology and Urodynamics, that Detrusor Underactivity is related to the afferent system. So of course we have used animal models, and we all have recognized this in recent years. But remember that no single drug for Detrusor overactivity or overactive bladder symptom complex has ever come from an animal model, because animals have a high non-adrenergic, non-cholinergic component. They do not have the longevity and age that we have, and using obstructive models, usually female animals with acute obstruction, is more akin to putting a stricture into a patient acutely, which is why you get a 300-fold increase in bladder volume and so on. 300% increase, sorry. So none of these are physiological models, and particularly putting noxious substances in an animal bladder has got nothing to do with overactive bladder. It's producing a painful bladder type syndrome. Management, therefore, going back to the Australian study I mentioned to you, it's no surprise that at the end of the day you can see intermittent self-catheterization or permanent catheterization or just observation are the mainstay of treatment. Of course, we can approach all of the different components of the underactive bladder. We can look at the obstructive component, we can look at bladder function and other circumstances relating to this. But ultimately, we have to think logically about how you manage these patients. Firstly, conservative management, behavioral treatments, avoiding fluid intake at appropriate times, emptying the bladder, straining to void and so on have all been used. But remember, this is a retrospective review from Bristol many years ago, showing that in fact only a limited number of patients actually do require surgery with large residuals. You can see it was around 12%, followed up for 4 to 5 years. So there's nothing new under the sun. You don't have to rush and do something because somebody's got a large residual. If it's a relatively low pressure situation, they're not troubled by infection, and whether you can manage it appropriately. Of course, bearing that in mind, catheterization needs to be used in many cases because of the storage symptoms or because of associated urinary tract infections. We do know that drug therapy has been advocated, but if you look at the Cochrane review and others, there is absolutely no evidence that cholinergic agonists have a positive effect or positive benefit, and they do have untoward side effects in patients. So I don't think anybody advocates their use in clinical practice. Electrical stimulation has been used, particularly in the pediatric group, and you'll see rather old studies that some of our colleagues present on a regular basis at this meeting, but there's very little evidence in the adult that this is a meaningful and appropriate way forward using direct stimulation, although we all accept the fact that stimulation of nerves, such as used for spinal injuries, can be effective. And with this in mind, therefore, there is limited evidence. People have looked in recent years at neuromodulation, and the lead for this meeting has produced some very interesting work here, which is published. But again, it also relates to the underlying intrinsic ability of the bladder to contract. If you haven't got a bladder that contracts, you can do all sorts of stimulation that you might wish to do, but it's unlikely that you can make it work. You can take a horse to water, but you can't make it drink. And others have produced very similar findings. Excuse me. Surgery. Well, of course, people have tried to reduce the size of the bladder. There is a group from Arno Stenzel who've produced a very nice multi-center study showing that in a very, very select group of patients undergoing quite complex, lengthy surgery with the latissimus dorsi, you can produce a positive outcome, but this does not reflect routine clinical practice and is not applicable to the majority of patients, out with very, very selected patients with certain neurological lesions, the Detrusor myoplasty procedure. So, forgive me, I think I'm just about on time, maybe 4 or 5 minutes over. Detrusor underactivity is a common problem. There's little published clinical or scientific evidence apart from the use of urodynamics. It's become a bit of a bandwagon which people are jumping on, but it's very important we still apply the good principles of the ICS to this, to look at the objective evidence, and you'll hear that from my colleagues now, based on good science. You've got to define what you're dealing with. You've got to realize what the underlying pathophysiological basis is, what the limitations are to the existing tools that we have available, to realize that there's multiple etiopathogenesis involved, and that there's a lack of a simple and effective treatment which we urgently need. And I hope that you'll come to the AU, just a bit of publicity, forgive me, because you'll hear all the latest developments well before the AUA or anything else. Thank you very much.